Good evening, everybody. Welcome to this ICA webinar on the very important topic, the AI anesthesiologist, from clinical practice to ethical frontier. And today we have the moderator, Dr. Pratibha Panjiar and Dr. Sumit Kalra, and there are four speakers today. Dr. Pratibha Panjiar is a professor at the Hamdard Institute of Medical Sciences and Research. In anesthesiology, her area of interest are the airway simulation, and she is this is a she is a instructor in BLS and the ACLS course and the medical legal issues. She has done diploma in medical legal issues from the Symbiosis Pune, and she is instructor already. I've told you in the ACLS and the BLS course. She has multiple international and national presentation, and she has got the best teacher and training award by ICA Delhi in 2022. Then she got the best award paper for the society by the Society of Airway Management in Chicago, USA, and at the Dublin, Ireland. Dr. Sumit Kalra is professor and head of the department. Senior consultant. Sorry, senior consultant at the Institute of Anesthesiology, Pain and Perioperative Medicine at our own institute. Her area of interest are the ultrasound-guided regional anesthesia, spine and the neuroanesthesia, and the pediatric anesthesia. He is the only one with the gold medal in the MD anesthesiology, which he late Dr. Anoop Memorial Award, which he did during the MD anesthesiology. And his work was very much appreciated during COVID-19, for he got the appreciation award from the Gangaram Hospital Trust Society. And he has written a chapter on the anesthesiology issues in COVID-19 in the book by the Gangaram Department of Anesthesiology, Gangaram Hospital. May I over to the moderator to continue the session, please.
Thank you, sir. Yes. Thank you, sir, for your kind words. A very good evening to all. At the outset, I would like to extend my thanks to ICA and especially to Jayashri ma'am for giving us this wonderful opportunity to present on this very upcoming and exciting topic titled as the AI anesthesiologist from clinical practice to ethical frontiers. So the term AI anesthesiologist is actually very thought-provoking. Actually, we are living in an era where technology is transforming medical science at a very unprecedented pace, and anesthesiology, being at the very core of the perioperative medicine, is no exception. So I think it is very important for all of us to understand not only the practical clinical implications or clinical applications of these AI in our field, because some of them we are actually using at currently at day-to-day practice, and many of them are to come, which we are going to discuss today in our webinar. But apart knowing these applications, it is also very important to understand the basic of AI. I mean, how it works, from where we can learn AI, what are its limitations, and also its ethical and legal considerations. So, through this webinar, we have made an attempt to cover some of these key areas of AI in our field. So today's session is divided into four topics. We will begin with fundamentals of AI, followed by its implications in perioperative care and pain medicine. And lastly, we are going to discuss how AI research and ethics complement one another. So without further delay, I would like to introduce our first speaker, Dr. D.K. Bhargava. Dr. Bhargava, please, can you share your slide, PPT?
Sure, ma'am.
So Dr. Bhargava is talking on, his topic is harnessing AI, curiosity, concepts, and structured learning. So Dr. D.K. Bhargava is professor and cardiothoracic anesthesiologist at the Army Hospital, Delhi. He has completed his MBBS and MD from the Armed Forces Medical College, Pune, followed by DM in cardiothoracic anesthesia. His areas of expertise include advanced perioperative echocardiography, cardiac intensive care, and extracorporeal life support. He has over 28 publications to his credit, with numerous presentations at national and international conferences. His academic contributions were recognized when his case image was featured on the cover of the Journal of Cardiothoracic and Vascular Anesthesia. He serves on the editorial board of the Annals of Cardiac Anesthesia and is a peer reviewer for many leading journals. He is actively involved in national academic events, such as conducting the hemodynamic monitoring workshop and leading academic quizzes. He has received multiple awards for academic excellence, including the Vijay Lakshmi Award, Best Paper at Society of TEE, Best E-Poster at International TE Conference, and Best Paper at Golden Fate Contest. Over to you, Dr. Bhargav.
Good evening, madam. Good evening to all the listeners and all the audience for this webinar. I hope I'm audible, ma'am, loud and clear. I hope the slide is moving.
Yes, yes, you are audible, but your
Sure.
slide is not moving.
Okay, right. So
Yeah,
harnessing artificial intelligence, the curiosity, the concept, and the structured learning. Firstly, let me give you a what do you call disclaimer that it's not a one-stop solution that I'm going to give about how you're going to learn. It's only pointers as to how it is going to work out. It may be different for different kind of people as to how you go up and learn new subject, especially once you're an adult. So, it has to be in our own part time as professionals, working professionals, how we are supposed to do it, and what is the suggested pathway, and how you can make the best use of the available resources. So, briefly giving an introduction about AI, there are so many things which look alike and sound alike AI. Like what's a program? A computer program, is it similar to AI? Or an algorithm, if I say, is it similar to AI? Automation, if I call it, is it similar to AI? And when we see virtual assistants, chatbots, are they similar to AI, or is AI really different? So if you want to find a good place for dinner using a search engine, is it artificial intelligence? If you want to find an answer to the problem, is it a computer program or an AI thing? If you automate a particular process, repetitive process, and make it repetitive without any failures, does this constitute AI? Or if you just ask it to follow a particular code that you've written on the computer, is it AI, or does it have something more than that? Then it's just a computer program. Robotics, how are they different from AI? And if you just schedule a meeting on your phone using a virtual assistant or a calendar, does it constitute AI, or is there a difference? Of course, there's a difference. Virtual assistant will just schedule a meeting, but it does not anticipate your schedule. So that's the small difference. A computer program will solve a new problem based on the instructions that are given. But if the problem changes, if there's a change in the set problem, naturally it doesn't work. So it learns, the AI thing learns after each iteration, each repetition, and just doesn't follow the instructions. And coming to automation, it adapts with each repetition, and just not a repetition of the earlier thing. And when you find a popular search that you use in the recent times with AI enabled searches, it doesn't give you search outcomes and websites links. It understands your requirements and gives you a summary, as most of us have experienced on our popular search engines. So, and then is it same at robot? No, it's the brain behind the body of the robot. Then coming to the core, that is it just a statistical technique, the new flavor of the season? No, it's not just a statistical technique. It measures, but at the same time, it learns patterns so that it can predict. The predictive ability is much higher than the usual statistical methods. The backbone is the statistics, but naturally, there's much more to it. And then, is it just a chatbot? No, it doesn't give you a script reply. It's much more than that. The moment you have AI-enabled chatbots, just the script, it goes beyond the script and gives you more understanding of your problem. So, a very basic thing is, how does AI work? What does the aim? It defines a problem, collects the data which is relevant to the problem, They prepares and cleans the data. It is all this is part of the AI application. AI doesn't do it. You have to do all these things. You clean the data, take care of the missing variables, take care of the variables which don't fit into a particular pattern, so that it can analyze it. Then there are methods to take care of the missing data, train and build the model, then test the model, evaluate its performance, deploy it in real case scenario, whatever case you want to use it, monitor and track and realize what are the shortcomings, and again define the problem, and they go along this cycle. This is the basic, a very broad understanding of how an AI application has to work. So now, conceptually, if you see, how does AI come through these stages? Initially it was the reactive machines which used to respond only to the current input. There is no specific memory as such, but once you give a large amount of data, depending on which pattern it fit into, it will play a particular game, or the various games that were played in the past, like the Go or the chess with the Deep Blue. Then came the concept of having limited memory, learning from the past data to make better decisions. So the what we know as the self-driving cars, the basic understanding is that. And then further ahead, we aim to go towards the understanding of human emotions and intentions, that is generally called the theory of the mind. And then finally we go towards the unity, that is the self-aware AI, which talks about possessing its own consciousness and self understanding. All that is still in the theoretical stage. Now, if you look at the capability based hierarchy of the stages of AI, this is more commonly known and more popular: artificial narrow intelligence, artificial general intelligence, and then self-aware AI. We are in between this ANI and AGI somewhere. So the cognitive ability has improved, but not yet there. At the same time, there is no consciousness. There are no other things which is basically the difference between a human being going about a problem and a machine going about a problem. So now, when we apply all these broad things into AI, we have our own, considerations and reservations. Let's say these two, as anesthesiologists, when we look at these airways, we know for certain that, it's a difficult airway. Right. So now, who will predict better? A seasoned anesthesiologist with a lot of experience, or an AI algorithm? For the AI algorithm to work, we have to teach the computer about the airway assessment, and we should translate all the metrics that we know of into numbers or codes. Looking at the picture, looking at some measurements, and then we should be able to transfer all the previous experience so that it is available to the novice operator. And depending on which difficult airway, depending on that data, which difficult airway equipment to be used, or the intubation technique to be employed, or what should be the rescue technique, and then unexpected situations, what are we supposed to do? All this has to be put into the AI, where it actually comes up and equals a good seasoned trained anesthesiologist. So now, will it be able to reach there, is what time would be able to answer. So if you look at the practice of anesthesiologist historically, it was initially about identifying cyanosis and hypovolemia by the color and the feel of the patient. But if you look at today's OT, like you can see in the background picture, you can see that you can see the table, the patient on the table there, and there's so many gadgets all around him. This is from ROT. You can see so much monitoring, so much equipment, so many infusion pumps, so much going on, and there's a huge amount of data which is coming up to the anesthesiologist. It was not about the feel or the color or whatever the objective or a subjective thing. It's becoming more and more objective. So by this massive amount of data that is being generated, it has given a level playing field for all levels of proficiency. So we are going that way. So if you look at data science, if you in the background of all this, if you look at data science, what are the requirements of data science to be applicable? First, it should be having a lot of volume. You should have a lot of data that of course is available. You should have a velocity of data. The data should be coming up. Obviously perioperatively we have tremendous amount of data which can come in, and then there is variety in data. There's a lot of variety which has to be. We have waveforms, we have pressures, we have variations in numbers, we have signals Then we have various kinds of electrical signals which are transformed into analog or in vice versa. And then finally, we also have comparisons between various parameters. So we have a tremendous amount of data and in anesthesiology. So now why this sudden interest? There's a lot of publications, of course. Why this sudden interest in AI in anesthesia? This, I'm sure, it's been there for so many decades already. But in the present scenario, what we have are large data sets in the form of electronic medical records. With those electronic medical records easily available with the help of hardware, which has got the technology to deal with such large data sets, and the cloud for retrieval of such data from anywhere, you also have the relevant AI architecture. So with all this coming up in place, along with the 3V, we have the perfect, milieu for AI to be applicable and, adopted in anesthesiology as a practice. So we have large data sets, then we have the AI architecture, that is the software capable for these application of these advanced algorithms. There's a large amount of data which can be handled, and at the same time, you can upload that data and download that data from the cloud. The cloud computing capabilities, all those things are available. So what is artificial intelligence in the right sense to begin with? It is simulation of human intelligence processes by machines, especially computer systems. If you go by definition, that is how it is. So systems that typically require human intelligence for visual perception, speech recognition, language translation, and decision making. So in total, what they try to do is they have learning, the acquisition of information, rules for using the information. That is the learning, how you're supposed to acquire that information, what is the rule for using that information. Like if you have certain interaction between two parameters, how are we supposed to interpret that? That is the learning. And then reasoning, using rules to reach approximate or definitive conclusions from that interpretation as to what the outcome would be, or predict something. And then based on its prediction and the final actual outcome in real life, you do the self-correction. If you look at it broadly, this is how AI is going to work. So now if you look at AI and anesthesiology, as I've already explained earlier, it's a perfect match because we have so much amount of data. The amount of variables that a patient generates per minute is phenomenal. Then we can have do have the capability to capture all that. In addition, we have in cardiac sciences the CPB data, in addition to the usual perioperative data, post-operative data, and then the disease trajectory between pre-op and post-op, then where to look, which is the first indicator. So basically, what is happening is the anesthesiologist is overwhelmed by so much amount of data. So the AI will give opportunity to understand where to look and which is the first indicator to look for in case of a problem or to predict a problem. So, and what not to miss. These are the things which certainly the AI will help us in each particular scenario. So depending on the disease process, we know that these are the risk factors, but in a particular combination of risk factors, a combination of patients, so and so patient going for this kind of surgery with this comorbidity. So what is the thing which has got a difference? Someone, patient on, let's say, yesterday we had a patient on methotrexate coming up for, let's say, cardiac surgery. So what are the implications and what is the data? So existing. So all this will be collated better with the application of AI, and it will eventually give us a decision-making tool or a decision-making support. Now, finally, there are so many, this has been dealt with multiple times in various publications. The standard definition is AI, machine learning, and other processes. Machine learning, the supervised, unsupervised learning, and semi-supervised learning, reinforcement learning, and then the concept of deep learning. And there are other things like the vision related things and the language processing methods. So if you look at it, these are the broad concepts in which AI is understood. Among the machine learning, there are various methods like the classical and the modern methods. The classical ones are the the standard statistics based methods, and the modern methods are a little more complicated. Then coming to the ML methods, I have already mentioned supervised learning, when you have a learning with a labeled data with a pre-specified output, whereas you know what is the output and you have a training set, you have a data set, and then identify what are the predictors of that particular outcome. Unsupervised learning is you don't have data which has been labeled; it's an unlabeled data, and you are asking it to the AI to the program to understand and find patterns. Then reinforcement learning is the learning through trial and error, like how the driverless cars are working. So then penalizing for a particular mistake, and then reinforcement for of that, so that you change your prediction method. So broadly, if you see supervised, unsupervised learning and reinforcement learning, but what are the problems that are generally dealt with by ML? That is classification, that dividing the data into clear groups. That these are the problems which are dealt with by using ML methods, and then regression models to understand relation between two variables. These are the broad concepts in which ML is perfectly applicable. So that is what we do on a daily basis. Either we predict or we classify into two different groups. So now, then there are certain other gray methods, grayer method, not just the black and white method, like the fuzzy logic, the decision tree algorithm, neural network, deep learning, and the Bayesian methods. Each has got a different specific application. Like for example, a fuzzy logic is when you don't have a 0 or 1, you are talking about different grades of a particular outcome, then you probably use a fuzzy logic. So then there are the other specific methods like the language processing and the computer vision. Like if you have free text in the electronic medical records, probably you're looking at a technique using the NLP. Then if you are looking at some images, then we are aiming to use a computer vision. With that background, if we see, there are so many avenues available in our daily practice where raw data sources are easily available. That is the electronic medical records, the radiological picture, lab results, then omics data, then clinical history, ECG, the genomics related stuff, then the biomarkers, and other various laboratory parameters specific to that disease. So based on this, there are so many publications. This is one of the earliest and earlier or detailed review article on this topic, where they have spelled out what are the various applications of AI in anesthesiology. I'm not going to go into these things because the other speakers are going to delve upon these things in detail. So my job is to tell you what are the resources available and how to go about it. With the advent of democratization, if I may call it, of the various computational resources that are available for all, we have de-identified electronic medical records not for our own hospital, but publicly available, like the Mimic 4 database, then the famous Amsterdam database. Based on this, the Amsterdam database, something, you have various societies conducting datathons every year for last so many years by professional societies, where you can form a team and participate in a datathon, and then understand how AI can be applied. Then availability of cloud sync and retrieval as per a particular user agreement for these databases. Then availability of Amazon Web Services, we all know that, and easily learnable programs like Python, and based on R-based or SQL-based statistical techniques and methods. And then, like I said already, there are so many PhD scholars who are already working on it. Doctors, after cardiologists, surgeons who are actively involved as PhD scholars in various institutes of national repute. They're already working on it and are actively getting trained in using these machine learning technologies. And then there are so many online courses, like I've shown on the right side, for programming and data science, specifically for all kinds of professions. The programs start with the basics, even for a non-mathematics background people, and build upon it over a period of 1 or 2 years. There are so many avenues already available. So what are the skill sets that are required? So if you look at the domains, what are the related domains? If you look at on the left side, the blue part, these are the hardcore artificial intelligence domains that are required. All may not be required for everyone. But if you look at the right side, what is data, what is statistics? This is how they are interrelated. The real world thing is the data, the application using the statistics, and then using the probability theory and the Bayesian theorem, you kind of develop a lot of models. This is how they interact with each other. That is the basic understanding with which you go ahead and understand the broad principles of AI and use a particular model. That is how I'd like to put it in a very broad set. Now, what is the skill set, like I said, required for being AI literate? First is you have to understand how AI models work broadly. Then you have to understand technical fluency of reading and interpreting data. You have to have a basic understanding of statistics, that is mandatory, and then develop upon that. And various probability theories are heavily involved in this, the Bayesian theorem or various then SQL techniques, SQL workbooks or CSV, all these things, you should be able to use Python over a simple data source that are freely available for practice. And then a lot of collaborative skills will be required between various professions, so that you learn from each other and amongst each other, and so that you can improve your workflow and see how it goes. And then also all these things with ethical and governance skills in place, so that the patient safety and fairness is always maintained. So if you want me to tell you a learning pathway, this would be how it goes. One should have a basic understanding of statistics and basic understanding of data science. I would like to stress again, these are a little different from each other. And then understand the concept of AI and existing applications of AI and various publications available in your own particular field. So whatever is your topic of interest or a field of interest, then one needs to dedicate at least 4 to 5 hours per week, depending on how one can this thing. And then there are various online freely available resources on YouTube, or paid courses on various online platforms, and also online courses done by various institutes. Then there are various online communities, like this particular community for doctors called the BrainX. It has got its own monthly newsletter, they have a webinar which they talk about basic stuff to various things which are freely available on YouTube. You can take a membership also. Then there are so many journal clubs which are available for online discussion specific to AI methods. And there are journals which deal only with AI in medicine. So then you take up certain small projects to collaborate your work presentations. So for that, first you need the foundation. Then you need to develop or understand what are the tools which are available, the Python, SQL basics. Then using the open databases, it's quite easy. Once you participate in one of the datathons, I participated in this ADS ICM datathon about 2 years back. So there are so many, so much available, information which is free to download. I mean, easy to use, free to download depending on the agreement that you have. And then so much scope for development. Then you can have your own data sets from your own sources depending on how you maintain them. Then apply them with collaborative projects. Then visualization is again an important thing which can be done. And then finally, ethics and publication, model evaluation, those are things which come up. So then one last thing is how to read a paper with AI application. First is, this is very important, to understand the clinical question. As a clinician, you have to understand, let's say intraop hypertension is what they're trying to predict. Let's say we have a lot of models. Then understand the type of AI model used. Is it a ML or a deep learning model or a NLP? So depending on what kind of data is being analyzed, you would apply that model. Examine the data set as a reader of that paper. What is the origin of that data set? What are the patient details? Have they been anonymized? What did they do with the missing data? So much data of thousands of patients. I'm sure there'll be a lot of missing data. How did they mute the missing data? Then does the data take care of diversity in such a large data? The next speaker is going to talk about it. Understand the model, what has been done for training and testing, and then look for the performance metric. That is, what is the area under curve which has been applied, or what is the diagnostic accuracy which has been reported. And then explainability tools. It's just a black box, or there's an explainability. There are so many techniques or tools called the SHAP tool, was one of them. Is it clinically logical? The clinical interpretation, is it clinically logical? Some vague association which is not really understandable is not useful for any of the clinicians. Then you have to go through the ethical aspects and of the application. Is the data anonymized? Is it broadly applicable? Based on, does it have a bias in terms of gender, age, all those things? And then finally reflect upon it in simple terms. So that is how you go about understanding an AI application. Don't get bogged down by so much of technical jargon. So next comes the question: in the era of AI, are RCTs obsolete? RCTs have got their own place. I'll make it quick. For specific topics where you have black and white kind of a data, you can still go out with particular techniques. But for evaluation new therapies or protocols, there is no data which is previously available, so RCTs are still relevant. Then the non-inferiority of a novel protocol, yes, of course, you have to prove it using a non-RCT. And then safety evaluation is always required in real-world studies of AI algorithms by, again, RCTs. So AI algorithms have to be, again, understandable by RCTs only. So that is again. So to conclude, I would say AI and anesthesiology. Time and again, people say it's the technology which provides the foot in the door. It may not provide immediate answers. It's for us to utilize the features of the technology to fill the room with light. With the availability of so much computational resources, electronic medical records, with 5G connectivity and cloud storage, and AI revolution, which is coming up and actually arrived. So we can have machines which have bedside unbroken attention even for a remote clinician. That is what we eventually aspire to achieve. But at the same time, garbage in, garbage out. If you have, if you throw in poor data quality, naturally the outcome is going to be this thing. And of course, the ethical part and the legal part still remain to be understood. So with that, I would like to conclude. Thank you so much.
Thank you, Dr. Bhargav, for such an insightful and inspiring talk. I hope
Thank
soon
you.
we all will be AI-enabled anesthesiologists following your insight and knowledge. I think we shall be taking all the questions and queries at the end of the session. So moving to the next talk, Dr. Samiksha, can you please share your PPT? Dr. Samiksha?
Yes, ma'am. Can you see it?
Yeah, it is quite visible. Just pick it to slide share. Yeah, so it gives me a great pleasure to introduce Dr. Samiksha, professor in the Department of Anesthesia at Government Institute of Medical Sciences, Greater Noida. Her areas of interest are chronic pain medicine, regional anesthesia, simulation, and artificial intelligence. She holds the European Diploma in Pain Medicine and has completed prestigious fellowships in interventional pain medicine and mechanical ventilation. In addition, she is a certified CCLS instructor and has also undergone the basic course in palliative pain medicine. She has made significant contributions to pain medicine education and practice and is also the founding secretary of ISSP GBN branch, Noida. Her topic is Revolutionizing Perioperative Care, how AI is transforming patient outcomes. So, Samiksha, please carry on.
Can you hear me, ma'am? I'm audible?
Yes, you are audible.
Thank you so much, ma'am, for such a nice introduction. I'm really humbled by it. So, starting with my topic, Revolutionizing the Perioperative Care, how AI is transforming the patient outcomes. So, as Dr. Bhargav clearly elaborated how the progress is happening in the technology and how we have to be at par everything that is going on around us. We talked about the pilotless cars, the flying cars initially, and it was just a fantasy. But as just to begin it on a lighter note, we all must be knowing that how into 2023 the US Federal Aviation Administration has authorized some retrofuturistic hybrid cars which can run on the roads as well as fly. So this is how fast we are running, and sky's the limit now. We very well compare ourselves to the aviation industries because anesthesiologists are very rightly called the pilots of human biosphere, especially of the perioperative medicine. And hence, just like the pilots, it's very important for us to be at par of the technologies which are being offered to us, the innovations, the robotic precisions, the reliability, and everything. We know what anesthesiologist does. All of us are anesthesiologists. So he who works with his hands and mind is actually an anesthesiologist, and we are simultaneously working on so many things. And we get overwhelmed by doing so many things together, be it monitoring, be it performing procedures, record keeping, many a time supervising more than one OR. So ours is one branch where AI can really, really be contributing not only to the patient benefit, but also to our benefit per se. So AI, the term, it was first introduced by John McCarthy in 1955, and in medical field, it has grown to umpteen levels in the last 2 decades. And presently, AI is actually used, we hear this word AI from even the kids around us. So it has become an umbrella term for all the algorithms and systems that are existing that Dr. Bhargav talked about, the tasks which can perform all kinds of cognitive skills like prediction, clustering, classification. We call it under an umbrella term of AI. So very, very superficially, if I want to talk about the components of AI, it is machine learning, and embedded in it is deep learning. So what is machine learning? When the computers are actually trained to apply the obtained knowledge. As told, when lots and lots and lots of data is input, and we've also given the output and the outcome to the computer. So what we get out of it after we are putting in an input of a new patient, of a newly presented data, is what is machine learning. So it is about statistics. It's about a statistics of, say, thousands and thousands of data that we've put in. However, if you talk about deep learning, it is more like our brain, how the neurons of our brain work. It is something which cannot be explained statistically. It is more of an analyzing part, in a very lay language, what our brain does, the interconnections, the intertwining of the neurons does, taking in a lots and lots of commands and trying to process it in an orderly way. That is deep learning, more like our brain. So if I want to give a very practical example with respect to perioperative medicine of machine learning, it is like, for example, if I want to predict the post-operative complication, maybe respiratory failure. So I have input in a lots of data, maybe patient demographics, comorbidities, whatever labs that I have, the vitals, the agents that I have given to induce the patient. And with the help of all this data that has been input and the outcome that I have entered into the system, this is going to use certain statistical models like, say, random forest or logistic regression. It is going to examine the thousands of historical cases in the data that has already been put in, and it will try to estimate the risk of the newly input data or the patient that we've entered. So the application could be, if with the help of ML, we are able to identify a high risk patient before only, obviously we are going to give this patient enhanced monitoring. We might reserve a bed in ICU for this patient. We might undergo certain preventive interventions preemptively for this patient. Talking about an example of deep learning with respect to perioperative medicine, it is good at handling the images, the waveforms. Basically, if you talk of the unstructured data. So the real-time monitoring, the real-time intraoperative monitoring that goes on with the various waveforms of ECG, SpO2, blood pressure waveforms. An example of it is if we want to predict hypotension even before it happens. So just by analyzing the real-time data events and the waveform, this DL component of AI may be able to detect the subtle changes of the waveform and might able to predict hypotension maybe 5 to 10 minutes before it actually happens. So it will help to alert the anesthesiologist beforehand. We can do the fluid boluses, we can do the vasopressors even before the hypotension actually sets in. So it will definitely contribute in improving the patient safety. If you talk about the algorithms, as already said, there are two major types of algorithms in artificial intelligence, the supervised and the unsupervised. So supervised are the labeled ones, where you input the data and you know the outcome. And you've also entered the known outcome for it. For example, during COVID, when we had put in lots and lots of chest X-ray images, and we paired them with the confirmed diagnosis as a COVID-19. So this algorithm is going to help us in identifying a newly input X-ray image. So here we've entered the outcome preemptively only. However, in an unsupervised algorithm, again, the outcome is not going to be known, and this algorithm is actually trained to perform the clustering and the grouping itself. It will try to uncover the new patterns itself. It will try to simplify the data. It will try to reduce the dimensions of the data, and it will try to come to a conclusion itself without any outcome that we have entered. We have not labeled this data. Again, coming to a very simple example of the supervised and unsupervised. Supervised could be, maybe we've entered a data set of maybe 1,000 patients of all the inputs that we have regarding the patient, and we've also entered a label that yes, this patient had complication, this patient did not have complication. So now it has been linked. It has identified the pattern which is linked itself to the outcome. So now this model is trained to estimate the risk of a complication of a new patient when we enter the data of a new patient. However, in an unsupervised learning, the data is entered. However, the outcome is not known. So now this algorithm is trained in such a way that it will try to categorize the patient's and form the clusters on its own. Maybe it will form one cluster of only young patients having low risk surgeries, another cluster of young patients having high risk surgeries. So it is going to form various clusters. It is going to try to uncover various patterns in itself, and subsequently it might become apparent to it that, okay, so and so cluster is developing higher rate of complications as compared to the other cluster. So it might reveal certain hidden patterns, certain unnoticed patterns in itself. So this is a pictorial representation of how artificial intelligence is working in perioperative care. Machine learning may be predicting the post-operative complications, certain logistics like predicting the risk of surgery cancellation. However, deep learning, as I already said, is analyzing the continuous data more so. Now here I would like to introduce another term, robot, because there is another thing, robotic anesthesia, which we'll be seeing in a while. So robot, we know actually it's something which is resembling a human, which is capable of performing complex human tasks or after being programmed in advance. So what is robotic anesthesia and artificial intelligence? How are they linked? Because many a times we've seen these terms being used interchangeably. However, it's not so. Artificial intelligence is actually the art of decision making. Robotics is automation and its execution. So to summarize this point, the robotic anesthesia uses AI as a component to make the decisions. However, AI can exist without robotics. Maybe certain purely software-based prediction tools, which are not doing any execution. They are just helping in decision making. The history of AI in perioperative medicine dates back in 1990s when the first ML algorithms they emerged and they started learning from the data independently. After that, there was this narrative review which described AI in three phases, which was pharmacological, mechanical, and cognitive. So, based on various systemic reviews, narrative reviews, and researches, it was discussed and it was concluded that AI has got the potential to stitch up all these three things together, and together it forms an autonomous system. And hence, we can classify the applications of AI in anesthesia as very important CDSS, clinical decision support system, and robots, which can again be pharmacological robots or mechanical robots. So CDSS system is also known as cognitive robots, and they are divided into two categories: the supervised and the unsupervised algorithms that we talked of. The ones which are created by the experts, and the other ones unsupervised, which are training themselves by identifying the repetitive patterns in the data collected. So these days we see the CDSS in the form of AIMS, Anesthesia Information Management System, which is existent around us in various phases. Some hospitals are at a preliminary stage of it. However, corporates, they have reached an advanced form of it. So they started from a form of a simple intraoperative record keepers. However, now we have them in a form of sophisticated hardware software solutions, which have been together integrated into the hospital's electronic health record system, and they are managing and documenting the patient's entire perioperative experience. Other than that, they're also helping us in logistics, in finances, in billings, and whatnot. Just to give an example of what AIMS can do, one, it is advising us regarding the compliance. Like, it can always guide us with what is the recent guideline, how do we adhere to it. Second is a very important function of it, a forced function. A small example, for example, if a patient came to the hospital, the patient is always assigned an IP, a unique IP code. So in the EHR, a unique IP code was entered. Now this patient is taken to the surgery. In the EHR, it was entered that this patient is maybe allergic to, say, Tranexa. Now intraoperatively, surgeon tells us patient ko Tranexa de do. Now, at the places, at the corporate areas where this AIMS is in full force working, the drug cabinets are also regulated by this IP system. If you need the cabinet to dispense a drug, you need to enter that IP address. Now, I want to give Tranexa to the patient. For that, I enter the IP address into the drug delivery cabinet. Now, when I enter that IP address, the cabinet is not going to open. It is not going to dispense Tranexa. Why? Because that IP is linked to the advisory that this patient is allergic to Tranexa. So This was a forced function where it did not authorize us to get that thing only out of the cabinet. Then, of course, maintaining records of all the values, as we already talked of, is another application of it. Coming to the mechanical robots, they can simulate the manual gestures. They have varied degrees of automation. It first started with the Da Vinci robotic system, and in anesthesia point of view, it was trained to perform popliteal nerve blocks initially. Then we have various robots for endotracheal intubations. There were robots for IV access. There was Hemobot. Then again, Kepler, Reality, they were all meant for performing endotracheal intubations. So the robots which are performing endotracheal intubations, of course, they have the promising ability to for the precise movement. They have the advantage of having an accurate navigation and ease of accessing around difficult bends, and of course we can do this procedure remotely as well. The KISS, the Kepler intubation system, was one such system that was being used, and it had a robotic arm which could be controlled with a joystick. And however, the endotracheal tube had to be advanced in manually. But because this procedure was taking a lot of time, there was fogging that was happening, it was later on abandoned. So it is still a long, long way to go before we can actually use these intubating robots in our practice. Coming to the pharmacological robotic system, how are they helping us? Of course, by managing the dosing of the anesthetic system, by the closed loop delivery system, appropriate fluid calculations, fluid management, by assessing they're linked to the ultrasounds, wherein you can assess what is the fluid deficit, and thereby again managing a closed loop system by managing the fluid, how much fluid to be given to the patient, etc. And various other aspects of perioperative care are there. These are some examples where the pharmacological robots are working. We have a deprefuser, we have a CLAD, which is a drug administrating system to dispense the medications to achieve the specific level of anesthesia that we need. Max Sleepy is something which we are very well aware of, which is using a combination of propofol, remifentanil, rocuronium. Sedasis, which was abandoned. Then you have various goal-directed fluid therapy models, which are again AI models, which are used to administer fluid boluses based on the hemodynamic parameters, various static as well as dynamic parameters they're using to monitor the fluid therapy in these patients. And then there are models for vasopressor titration. They're also based on the blood pressure monitoring, the stroke volume monitoring, the cardiac output monitoring that way. So if you talk about how AI and is converged into the perioperative medicine, how it is helping us, how it can help us in prospective future is, of course, it can help us customize anesthesia plan, based upon the subjective needs of the patient, appropriate combination of the drugs, their doses based on the real-time data. Then by doing a real-time analysis of various vital signs and whatever critical data the patient has to offer, as I already said, it can help in early detection of various complications like hypotension, hypoxia. It is this monitoring can be actually real-time, continuously analyzing heart rate, BP, saturation. These algorithms, they can together recognize even the subtle deviations that happen from the baseline values, and it can also help identify some complex pattern that happens, which can signal even what is the underlying problem that is causing all these things. Then, of course, prediction of the risks of anesthesia, the post-operative surgical complications, be it respiratory, be it cardiovascular. So again, these are working on the prediction models. As we talked of is labeling, the supervised algorithms that we talked of. So if we've predicted the post-operative surgical complications well, of course, we are going to be able to give recommendations for its management even preemptively, even before they happen. Then it has got a very good advantage in maintaining the logistics of operation theater. The risk of cancellations of surgeries, the expected duration of the surgery. So with this, the usage of operating theater can be scheduled very rightly, maybe predicting the length of hospital stay of the patient, the risk of readmission of the patient. So everything is going to help in managing the costs as well as the finances of the hospital as well. However, there is a lot of ethical considerations when we are talking about using all this data of the patient, okay? Patient autonomy, which is very important. Informed consent, to what extent does the patient want us to use their data? The data privacy, and the algorithmic bias that can happen by the difference that we can have in the number of inputs that we are giving to the system or the computer. So, of course, what is needed is strong data protection and maybe a different consent from the patient if we are going to use such a data in the AI technology advances. So this is the summary of how the AI is working beautifully in the perioperative medicine, or we can say how it is going to work. We have a closed loop anesthesia delivery system, which is being governed by the vital signs and various monitoring systems like brain monitoring, heart monitoring. Then we have got the CDSS, which is including the various guidelines, forced tools, and risk assessment tools, which can again help us take a decision with respect to patient, or maybe take a decision on our behalf as well. Then teleanesthesia, and of course the mechanical part of it that we've talked of, maybe in the field of airway management, airway assessment, performing procedures, regional anesthesia, maybe in chronic pain management as well. So I think this is what I have to say in the perioperative AI briefly. Thank you, ma'am.
Thank you, Samiksha, for a truly engaging session. I think you have beautifully highlighted how AI can be integrated into our routine practice to improve patient outcomes. We will come back to you at the end of the session. Now, may I request Dr. Sumit to please introduce our next speaker?
Thank you so much, Dr. Pratibha. I agree with you. Dr. Samiksha has indeed delved very, very deeply into the perioperative role of AI. And there's a lot to, I think, ponder and learn from this talk. I now please kindly request Dr. Sana Yasmin to share her screen with the CV.
Yes, sir.
Dr. Sana is an assistant professor at All India Institute of Medical Sciences, New Delhi, and she'll be talking on AI-powered pain control, a new era in acute and chronic pain management. Dr. Sana has a special area of interest in chronic pain in obstetric anesthesia, labor anesthesia, and research. She has had many publications and awards. She has successfully done the Indian Diploma in Regional Anesthesia, the Fellowship in Interventional Pain Medicine. She's a certified BCLS and CCLS instructor, and she is also trained in quality control in healthcare, NABH, and she has received the Best Paper Award at ISP Con 2024 on chronic pain, awarded a certificate in pain medicine, has numerous multiple publications in journals, and also a reviewer of the journals. Welcome, Dr. Sana Yasmin Hussain. The stage is yours. All the best.
Thank you, sir, and thank you for the kind introduction. So I'll be talking about the AI-powered pain control, a new era in acute and chronic pain management. So the previous speakers have already discussed the basics of AI and its applicability in anesthesia. I'll be touching upon the specific uses of AI in pain medicine, its various applications that are being used in acute and chronic pain, and the barriers that we are facing, and what can be the future direction and how we can integrate it in our clinical practice. So artificial intelligence technology has developed in medicine a lot, and it has been really transformative. However, its applications in acute and chronic pain still remains underexplored. From the various studies that are being done and from the early implementations of AI, including machine learning and deep learning, the results are quite promising, and it shows that how we can revolutionize pain management, including assessment and the treatment of pain. So coming to the challenges of traditional pain management. So as we know that pain is a very complex interplay of sensory, emotional, and the cognitive processes. And hence we keep on talking about the biopsychosocial model approach of model of pain. And the approach to patients are always multifaceted. That is, one size will not fit all. There is no one single medication for one disease entity. And one of the major clinical limitations that we face as pain physicians is the subjective nature of pain. And this subjective assessment leads to inconsistent treatment modalities. Also, there are very limited objective biomarkers for pain, unlike other diseases where we have objective biomarkers. There's a very heavy reliance on the use of opioids, and this creates the risk of opioid dependence. Also, in busy clinics, personalized care, which is very important in chronic pain, is missing, and a blanket therapy is being given to patients. So, because of these unmet clinical needs, AI can actually become an integral part in the diagnosis and the treatment of pain. And we can move from subjective to objective assessment of pain, and also from opioid dependent management to multimodal treatment methodologies. So, how is AI transforming pain management? First of all, it includes a large data set which it can be obtained from the patient records and the pain trends of the patient. Then machine learning enables the predictive analysis that is AI can anticipate the pain patterns in patients, and which patients will have more pain, and how can patients go from acute to chronic pain. And computer vision will detect the facial and physiological pain cues, and integration of machine learning and computer vision can then help in diagnosing and predicting the pain patterns of the patient. This will help in personalized pain management. AI will recommend the targeted interventions, and it will decrease the dependence on traditional drugs. So machine learning applications in pain medicine include various modalities. That is, the first is the pattern recognition. That is, the deep learning algorithms will identify the pain patterns and the progression markers. There'll be predictive modeling. That is, the neural networks will predict the treatment responses, and then they will identify what can be the optimal therapeutic strategies for individual patients. It can also help in drug selection, which is very important. That is, which analgesic agent will be most effective for which type of patient population. And then it can also help in the outcome analysis to refine our treatment methods. The various benefits of AI based pain management includes personalized intervention. This is very important in pain patients, as we cannot have a single treatment approach to different types of patients with different types of pain. And hence, AI can enable the precise, individualized treatment plan, and it can fit into patients' unique profile in the response patterns. Also, opioid dependence is a very big challenge, and the smart algorithms that are developed using AI can actually identify the opioid sparing alternatives, and they can also predict the addiction risk of the patient, and they can minimize the reliance on the harmful medications that we prescribe. The predictive models can help in early intervention, and the continuous monitoring, that is the real time tracking, will improve the patient engagement, and it will also help in treatment adjustment. Also, workflows can be streamlined by using natural language processing. It will enhance the physician efficiency and improve the doctor-patient communication quality. So this is a framework of the potential AI ecosystem for pain medicine. It ranges from diagnostics to the objective pain assessment to resource management and logistics, research innovation. Pain prediction is a very big, AI can help in pain prediction in a very big way, and the prognostication of pain. It can help in treatment selection and the implementation of strategies. It can then tailor-made and adapt the treatment technologies that we're using, and also it will help the patients in self-management of chronic pain. So this shows the various applications in which AI is already being used in pain, and the number of studies that has already been done. Almost 20 to 40 studies have been done, spanning from treatment planning to treatment delivery. And that includes acute and chronic pain prediction, treatment decision aids, medication and dose response prediction. And the treatment delivery studies includes the self-management applications, use of advanced ultrasound guidance, and the real-time treatment tailoring. So coming to acute pain, AI models can actually predict the post-surgical pain trajectories, which is difficult, and to predict as such that which patients will have severe pain after what type of surgery. So the AI models can actually predict that, and we can tailor-made our treatment methods likewise. It can also analyze the facial expressions, the micro movement of the patients, the physiological signs like tachycardia, tachypnea, to detect the acute pain instantly. Also, post-surgery monitoring can be done, and the closed-loop systems can help in adjusting the analgesics in real time. This will decrease the risk of acute pain transitioning into chronic pain. And AI-powered ultrasound-guided blocks are a very interesting arena that is upcoming. And development of AI-powered robotic assistants can also be done for ultrasound-guided procedures. For acute pain, there were various studies that has been done. So a machine learning algorithm was developed to predict the breakthrough pain in labor with labor epidural analgesia. Similarly, a model was developed to know the pain after total knee arthroplasty. So how can AI help in pain assessment? The most common way is to do a facial analysis. That is the facial features of the patient. Also, voice analysis can be done. That is the way the patient, the tone, the in which the patient is talking, the cry of the baby. This can all be analyzed to detect what is the intensity of pain. Then the breathing of the patient and other vitals can be seen by using wearable sensors. The body posture, that is how is the patient sitting, that can help in assessment of pain. Also, the doctor's notes, the electronic health records, they can all be fed into the system, and all this can help in assessment of pain. So this is a basic model of how AI helps in pain assessment. A video surveillance is done where the facial features are of a normal patient is assessed, and a lot of patients from different features from patients who are in pain, their facial expression will also be noted. Then the machine learning analysis is done, and it not only then detects pain but also grades the pain intensity. So this was a study which was published in the Indian Journal of Pain, where the primary observation from the facial features was done. For example, the glabular frown lines, the grimace, the grim face, the lowering of the eyebrows, and the squeezing of the eyes. All these features were taken into account, and an artificial neural network algorithm was developed for pain assessment. So it can be used in adults and children, and this is how the facial mapping is done. Pain assessment in special patient groups will be very important as it adds objectivity to our assessment. For example, in neonates, elderly, patients who are on mechanical ventilator or with cognitive impairment. There was a study which was published in Pediatric Neonatal Pain Journal, and it showed that a model was developed using the video, that is the video of the facial features of the child, the cry, that is the audio, and the vital signs. They were all integrated, and pain assessment was done, which led to early pain detection and intervention. Hence, we see that AI for acute pain management involves advanced detection using the computer vision, then real-time adjustment of the drug doses, and which will further enhance the accuracy of the diagnosis and the treatment methods. So data can be obtained from pain assessment tools like the Wong-Baker Faces Scale, the numerical rating scale, and from the vital monitors like the heart rate variability, the depth of respiration, blood pressure, pupillometry. All these data can be integrated by ANN, which will then guide the perioperative pain therapy. So we have to understand that although AI will help in this, but automatic pain detection remains complex, and we need to keep in mind the various medical conditions which might affect the AI assessment of pain. For example, the facial shape and mobility, as in diseases with Parkinson's, stroke, facial injury, or congenital deformities. Despite these drawbacks, there are studies which suggest that AI and machine learning algorithms will perform better than human observers at differentiating genuine versus fake pain expressions. Now coming to the AI-assisted ultrasound guidance. This is a very interesting arena which is being developed, and no doubt it enhances the safety and improves the outcome of the patient, decreases the risk by decreasing the risk of local anesthetic systemic toxicity, and prevents injury to vital structures. A ScanNav anatomy system has been developed, which is based on the AI technology. It is already FDA approved. So we can see that the B mode ultrasound video was used for peripheral nerve blocks, and each video frames were broken into multiple frames, and they received a colored overlay, which were then labeled as either landmarks, the safety structure, or the targets. These frames were then used to train the machine learning algorithm, and which then used deep learning to develop associations between what the various labels and the underlying structures. For example, we can see that during the real-time ultrasound, these colored overlays of the structures in the adductor canal block showed the various muscles, the adductor canal, the vessel, and the nerve. This study was done to validate this technology, and there were 3 independent experts. The 40 scans were done, total of 275 assessments was done, and an accuracy of almost 80% was found. So we can see that in the supraclavicular block, these are the colored overlays of the subclavian artery, the nerve plexus. The rib is colored blue and the pleura is colored purple. This is of the erector spinae plane block. So it basically showed colored overlays. So we can actually see the structures. There is no confusion where the pleura is. We can safely avoid the vital structures, prevent vascular injury, prevent injury to any important structure because they're very clearly visible with the colored overlays. So this is the rectus sheath block, and this shows the adductor canal block. There was yet another study which was done using deep learning for recognizing the femoral nerve block. So this shows the real structure, that is the femoral nerve, and this was predicted by AI. So the intersection over union, this part intersection, this shows whether AI correctly predicted the real structure, and this was known as the IOU. So as the IOU increased, we can see that the actual structure and the AI predicted structure will correspond. So when the IOU was less, the structures were a little apart. However, in the study, it was found to be 70 to 80% accurate, and AI quite correctly predicted the structures on the ultrasound. This is also a very interesting technology where automatic spine level identification system was developed using a deep convolutional neural network. The various scans were done, and the sacral vertebra, the look of the sacral vertebra, the lumbar vertebra, the interspinous scans, the interlaminar scans, they were all fed. And then it was trained to know at which level we are in. So this is how the scan was done. It was then also attached with the augmented reality system, and this is the ultrasound probe. So now it can detect when we place the probe on the patient's back during the pre-scanning, it can actually detect where we are. So this shows the current level, that is L4, L5, that we are in the interspinous space. And because of this augmented reality system that has been attached, we can actually see that we are at L4, L5. So now coming to the role of AI in chronic pain management, there are various ways in which AI can help in chronic pain management, and it includes the risk prediction, that is which patients will develop chronic pain, the medication and dose response prediction. We can monitor opioid use and decrease the risk of opioid use disorders. We can have real-time treatment decision aids and develop self-management applications. So there was a study in which prediction model was made for chronic post-surgical patients in breast cancer. So it showed a lot of predictors. This model was developed, and it showed almost 6 leading predictors like the axillary dissection, postmenopausal status, and other predictors. So this was developed using the machine learning. Coming to yet another important application is the medication and dose response prediction. So in chronic pain patients, it is very difficult to predict which patients will respond to one particular drug. AI models can help in predicting from the various patient characteristics that which drug might help in which sort of patients. For example, 2 studies have been done which evaluated the patients of fibromyalgia and chronic pancreatitis, and they assessed whether through the AI models whether they will respond to pregabalin, and it was also found to be around 70% accurate. It can also help in dose optimization, that is at what dose should be starting an analgesic. So the response prediction and dose optimization will actually help prevent the trial and error method that we do. We start with an analgesic, change it if it doesn't work in chronic pain patients. We start with a lesser or a higher dose and then titrate it according to the effect and side effects. So if AI is used, this can actually prevent the trial and error method and help the personalized approach to patients and better safety and decrease the cost of treatment as well. AI was also used in functional neuroimaging. So there are various brain areas which show changes in chronic pain patients. So functional neuroimaging was done, and using the AI model, it was predicted in fibromyalgia patients that using the neural markers that which patients will respond to which drug, that is pregabalin or milnacipran. And it was found to be 77% accurate. Now, the use of AI to predict patients' response to therapy. So there was a study which was done to which used the convolutional neural network algorithm. It was trained on the lumbar spine radiographs, and it predicted outcomes of the transforaminal epidural steroid injection. That is, which patients of lumbar radiculopathy and spinal stenosis are going to respond to an intervention of TFSI. This was found to be almost 87.2% accurate. Coming to the opioid associated risk prediction. So this can actually predict the risk based on the demographic factors, the medical history of the patient, the psychological profiles, and it can assess the addiction vulnerability of the patient. So it will help in early implementation of opioid sparing techniques, and it will help us in designing the alternative pain management strategies as well. And it will decrease the risk of opioid addiction in patients. Also, when the patients are transitioning from acute to chronic pain, the patient's participation in their own self-management becomes very important. There are various psychological factors which play a role in the creation of chronic pain and the maintenance of chronic pain. And pain psychologists are very limited, and it takes a lot of time. So AI-generated powered chatbots have been made, and it can actually create cognitive behavioral therapy worksheets at home, and patients can actually do that, which will provide accessible mental health support for these patients. The use of virtual reality, augmented reality can also help in relaxation techniques for these patients. Also, ML algorithms have helped in tailoring the at-home exercise therapy, which can help in musculoskeletal pain patients, and personalized exercise programs can be developed. The smart applications can guide the analgesic intake and guide patients on what medications to take, and it can help in optimal pain outcome. There are various AI tools and devices that can be used for pain patients. That is the biosensors for real-time pain tracking, pain diaries as such a very important, and we tell our patients in pain clinic to maintain a pain diary. So smartphone-based pain diaries can actually be very helpful. Then we can have AI-assisted infusion pumps for delivery of analgesic agents, and neurostimulation control systems can also be developed. The other uses include the remote monitoring systems and the use of teleanalgesia. It can also be used in neuromodulation. That is, when it can detect when the device, like the spinal cord stimulator or other devices are malfunctioning, and it can optimize the stimulation parameters. Then image optimization is yet another very interesting arena which can help in chronic pain management. That is, the AI in fluoroscopy can actually differentiate between the optimal and the suboptimal images, and it can enhance the dye spread and injection accuracy. So AI pattern recognition will identify what are the optimal zones for needle advancement, and how do we go about the procedure. This is a potential workflow of a future pain clinic. This is a hypothetical scenario right now, and we can actually implement it. So it shows that AI can help in the pre-visit planning. That is, the patient will upload all their data, their medical records into the system, and the AI will then formulate the differential diagnosis pre-visit, and it will then recommend the patient what further workup can be done and what other investigations to come to when they have the clinical encounter. So during the clinical encounter, that is during when the patient comes to the pain clinic at the first time, the pain physician then gathers all the information, examines the patient, makes a diagnosis. At this stage also, AI can help in having differential diagnosis, and it can also recommend the doctor for any specific diagnostic studies to be done. Additional workup can be done, and this can all be stored in the data and the patient's electronic medical records. And AI will then recommend through the predictive models what are the best treatment approaches, what medications to give, and at what dose to start. And finally, after the treatment has started, the diagnosis and treatment is being done, the AI can actually follow up the patient and then tailor-made the treatment plan and recommend various other changes. So to summarize, the AI workflow in pain management includes the data input initially, the model has to be trained, then it helps in prediction analysis, and finally, it helps in the clinical decision support. Now, coming to the challenges that we face in AI implementation in pain medicine, first is the data quality. That is, the quality of data that we want to feed into the models is very important, as the pain is very subjective, the population is very diverse, and if there are any biases in the data that we are feeding into the models, it will reflect accordingly. So standardization of data is also very important. Validating it and generalizing it to the population is important. The cost that is involved in developing the AI models for infrastructure and for training the physicians and other healthcare providers is also a challenge in implementing AI. Then data privacy and patient consent is one of the other factors that we have to take care of. Then the technical integration is important. That is, we cannot develop AI models standalone. We have to integrate it into the existing workflows and the electrical health record of the patient. So what can be the future roadmap of AI integration? First, we have to define the problem. We have to identify the clinical gaps that we face in our day-to-day practice, and then design our AI systems and AI models to fill in these gaps. Then we can integrate this multimodal data, for example, from the genomics, from the radiographs and the patient clinical behavior, and then develop a model. The algorithm development and validation will take place. Then we have to adapt these applications into clinical areas, and also conduct training programs for physicians and other healthcare providers on how to use this AI technology into our day-to-day practice. And finally, then we deliver personalized pain treatment to patients. So, to summarize, AI augments and does not replace the clinical decision making in pain medicine. It enhances the precision, prediction, and personalization. It will improve the clinical efficiency and patient satisfaction. It requires algorithm transparency. It requires clinician and AI collaboration, and ethical frameworks are essential, which will be discussed in the next talk. And the future of AI in pain medicine lies in translational and patient centered research. And in the end, I would like to reiterate that success in this field will depend on careful clinical validation, ethical scrutiny, and an unwavering commitment to preserving the human touch in patient care. Thank you.
Thank you so much, Dr. Sana. That was indeed a excellent talk. And yes, we totally agree that the human touch has to be incorporated. I now request Dr. Prakash to please share his screen. We'll have the questions at the end, Dr. Sana.
Yes, sir.
So, Dr. Prakash is an assistant professor at the AIMS New Delhi with the area of interest being patient communication and using generative AI, critical care medicine, and simulation and innovation in medical education. He has had many publications and awards, including IDCCM, has multiple index publications, has the best international oral presentation recently at SANCON ASPA 2025, and best poster presentation at Patient Safety Research at AIMS New Delhi. He'll be talking about on AI research and ethics, balancing innovation with responsibility. Dr. Prakash, the stage is yours. All the best.
Good evening, everyone. And I have a good news that I have the least amount of slides, and I'll quickly guide you through the very important topic, which is AI research and ethics. So, the learning objectives of today's session is, firstly, we'll explore how AI is transforming the anesthesia research, understand the latest released ICMR's ethical principle, discuss and reinforce what is research integrity, especially in the shadows of artificial intelligence, and reflect finally on ethical AI safeguards, how it improves patient safety and public trust. So, AI is now embedded in almost every aspect of upcoming researches, including pain, pediatric anesthesia, say bariatric, critical care medicine. These systems learn from human data, as previous speakers have already highlighted. And ICMR back in 2023 and an updated guideline in 2024 warns us about the misuse or about especially about unvalidated AI. We should ensure that innovation, which is at a great speed, should benefit and not harm the patients. And research integrity, of course, forms the foundation. We all are aware about the pillars of ethics: beneficence, do benefit for the patient, do no harm, autonomy, and justice. Courtesy to ICMR, they have introduced 10 AI ethical principles. We start. We start with autonomy, then collaboration, risk minimization and safety, accessibility and equity, optimization and data quality, non-discrimination and fairness, very important. We'll come about it. Validity, trustworthiness, accountability and liability, and of course, data privacy. Again, very important. So, as previous speakers explained it quite well, AI impacts research on multiple domains, from project design to publication. Let's consider a hypothetical scenario where a group of anesthesia residents, nowadays they are using ChatGPT quite commonly. So they generate data which is fake or AI generated, let's say AI generated, and get it published, get that data published somehow. This is some new drug A versus B. For our understanding, as we are well aware with propofol and etomidate, and role of etomidate over propofol in cardiac patients. Let's say the fabricated data shows the drug A or propofol is safer. Somehow these multiple RCTs are handpicked by a meta-analyst, and he generates a meta-analysis followed by multiple meta-analysis, umbrella analysis, and this comes into guidelines as a top level evidence. Slowly people start practicing it, and a few patients develop refractory cardiogenic shock. Some may even die. So the question is, who is responsible, or what, and on how many grounds there was an ethical collapse? So in non-malfeasance, yes, it was affected. Beneficence affected. Autonomy affected. Justice affected. Now, coming to a primary question, who is actually responsible? The residents who forged the data or faked the data, the peer reviewers who might have used AI in their peer reviewing, the guideline committee who uses meta-analysis as a level of evidence, or the AI tool or developer. So this is a gray area, and I will express some light on this. Just to highlight, the research misconduct in the age of AI scales from one paper to one practice to one patient death or comorbidity. So let's talk about framework of ethics at every stage of AI research. We should be very vigilant and make sure that design at every stage of research, especially stages like design and proposal, data acquisition, model development, validation, deployment, and dissemination of the results, and eventually publication, all have inherent risk when AI machinery is used, be it in form of developed software or generative AI, and there has to be some safeguards. For example, in design, we should define what is the utility of AI and define patient benefit. For data acquisition, we should obtain explicit informed consent. For model development, we should use explainable models and avoid those models which have a black box effect. Then validation and deployment, we should conduct pilot validations, and of course follow ethical protocols and committee of publication ethics and international committee of medical journal editors guidelines in dissemination of AI, use of AI in research. So let's come to research integrity. What is its definition? It implies honesty, transparency, accuracy, and accountability in the entire research process. It starts from the thought of the idea and to the ultimately to publication. With AI, there is innovation for sure, but it is at a very rapid pace, and somehow integrity is slow or is questionable. People are using AI. I've seen many people, they don't even disclose the use of AI. And there are softwares which detect AI text or AI content. It is also at the nascent stage, and there is evolving. It is an evolving technology. So what happens and what kind of breaches are there? So fabrication and falsification, as I mentioned already, plagiarism or AI ghostwriting, hallucinated citations, there can be lack of disclosure and data mismanagement. It has implication in anesthesia and in a broader aspect in most of the fields of healthcare. What it leads to is a unsafe and invalid clinical recommendation, and it erodes trust both in the clinician and the quality of research. So what are the duties of researchers in AI based study? First and foremost, accountability, and it should be clearly mentioned in the declaration that authors are accountable for the scientific content. Transparency, again coming to declaration as given by ICMJE, validation, data stewardship, and collaboration ethics. In a recently published article in Curious this year, midsummer, so there was a meeting of International Committee of Medical Journal Editors recommendation, and they have highlighted use of AI and how it should be dealt with in clinical research. There should be acknowledgement of AI technology in the work and use of AI in review of manuscripts. Many reviewers are now using AI chatbots, which are freely available for medical public scientific scholar papers review. An editor should be aware that use of AI in manuscript processing could compromise confidentiality. I'll come on this point in next few slides. So what does ICMR or the controlling body requires or expects from us? AI cannot be listed as an author. Only humans meeting ICMJE criteria can be. Disclosure of AI assistant. So many people have that doubt, how should we disclose it? So a simple statement can be portions of this work were generated with the assistant of XYZ tool and the authors verified all contents. Editorial and peer review ethics should be mandated. AI detection audit should be done, and editors should reject submission with unverifiable AI generated data. Another framework for oversight and accountability is a very important role by the Institute's Ethics Committee. It must evaluate AI specific risks, especially data privacy. Approve only those projects with defined human oversight and validation plans, and require consent language specific to AI use and secondary data analysis. ICMR also recommended there should be an AI ethics subcommittee, independent audits, which should be periodic, and mandated incident reporting for any ethical breaches. And of course, institutional responsibilities are also playing a primary role in having oversight and accountability over AI researches. How can we prevent? This institute can have research integrity officer under IEC, adopt a code of conduct, which I'm sorry to say is missing still at this date at many institutes. Ensure all AI research pass a bias safety and data security audit and mandate training programs. On project level, safeguards can be data provenance log, validated data sets, HITL or human in the loop clause. ICMR recommended audits and accountability. ICMR does encourage ethical AI audit trails. Looking at from a SWOT point of view, strength, weakness, opportunities, and threat. AI in research it can give you good research ideas, refine the abstract manuscript, it can analyze vast complex data, develop an algorithm. Weakness is limited accuracy with unreliable output, plagiarism, falsification, lack of critical human judgment, and something called as waffling, which is a large amount of text but only few scientifically important points. Opportunities, it summarizes vast medical literature, good assistant for experienced researchers, help non-English speaking speakers to write or translate data. Threat, it ethical concerns with legal identity of AI, lack of transparency, lack of regulatory structure, infrastructure, risk of eroding trust. So what are the laws that are currently there in India especially? So as of now, India does not have a dedicated regulatory framework. The challenges still remains lack of comprehensive AI specific legislation, bias and discrimination in AI system, privacy concerns, deep fakes that are very common nowadays, AI accountability and liability. But the situation is not that bad. Some of the existing laws do cover or I can say govern AI use in research especially. So Information Technology Act 2000 under section 43A compensation cheating by impersonating and obscene publication. Case law, there was a case with Justice K.S. Puttaswamy versus Union of India in 2017, which highlights the right to privacy as a fundamental right, and it further implied on use of AI. Digital Personal Data Protection Act 2023 highlights the data protection principle. Again, Information Technology Rules 2021, Draft National Data Governance Framework 2022. It express a concern over repository of datasets, large datasets related to healthcare. National Strategy for Artificial Intelligence 2018 by Niti Aayog. It gives the concept of principles of responsible AI. This was revised in 2021. Rules on deep fakes and misinformation is covered under Section 66E of IT Act and Section 509 of IPC, now BNS. The Digital Information Security in Healthcare Act Disha 2018 by the Government of India. It highlights electronic health data privacy, confidentiality, security and standardization. So most of this legislation or acts does cover some aspect of misuse of AI, but there is of course a clear need for AI specific legislation to address the complexities and ethical concerns with use of AI technology. The ethical compass of AI in anesthesia research depends on transparency, accountability, data privacy and safety, scientific integrity and equity and fairness. So how can we balance and move forward? So ethics is unavoidable and it is the foundation of trustworthy AI. Research integrity does protect patients at larger scale. Human oversight is irreplaceable. Human in the loop has to be kept in mind. Transparency is non-negotiable, and India is setting most of the even developed countries, they don't have a proper legislation, but ICMR back in 2023 and 24, they revisions in 24, they have good guidelines that cover mostly most of the domains of AI use in research and healthcare. I just want the audience to have a thought about what are these AI hallucination, why there is fake data or fake citations, or what are these AI hallucination, why do these happen? So I request the readers to, if they have time and interest, then they can scan this QR code and read a good paper authored by me and my colleagues on AI hallucination, especially related to anesthesia. This is my last slide. I suggest for further readings, they can refer to mainly this ICMR guidelines and then recent papers which I'm mentioning here. Thank you so much.
Thank you. Thank you, Prakash. That was indeed a quick snapshot into the things. Very, very nicely presented.
Thank you, sir.
We Dr. Pratibha is here, ma'am. We don't have any questions per se in the chat box, but I would like to start the discussion with Pradeep sir is here. Pradeep sir, good evening. Sir, you are muted, sir.
Okay, okay.
Yes, sir.
Yes, sir.
So we can start the discussion with the, I think, Samiksha's topic. Samiksha, you're there?
Samiksha, are you there?
Uh,
No issues. I think she'll just join back soon. Dr. Sana, we can take a question for you. What all the AI integrated equipment are you using in your pain practice right now, in this moment, in this era?
Right now, we are not using as such any AI integrated this thing, but we are conducting a multicentric trial where we are developing a large data set for patients of chronic low back pain. And we are then going to generate a model where patients can diagnose whether what is the diagnosis and whether they need to see a physician for that, or just will they be okay with lifestyle changes. So we are into the process of doing that. The study is currently underway, but as of now, we are not exactly using any AI based tools in our pain management strategy right now.
is there some data, Dr. Sana, as you can ask you, some data regarding the back pain, which procedure with the MRI diagnosis is going to be helpful, whether it is coronal epidural, transfemoral, or as such lumbar epidural that can be taken decision by the AI.
So it will need a lot of data, like the clinical data, the scans of the patient, if it is available. For example, if the patient just complains of a non-specific back pain versus a patient who complains of a specific pain which is radiating to the leg, that is a dermatomal distribution of pain. So then through that data analysis, we can know that the patient probably has a foraminal compression and is developing a foraminal narrowing, which might need further workup, MRI, or a pain intervention like a transforaminal epidural steroid injection. So this study was also done, which showed, which could predict which
Is
patient.
the prediction of the result
Yeah.
is possible? Prediction of the result, at least prognosis, let's say, how it is going to be helpful, whatever is this
It will
thing.
be helpful. So it will obviously need clinical methods and our clinical examination, which should be integrated with the AI algorithms. Only then we can decide on the final patient management.
Can I
However,
ask you another question? Is the
yes,
PCA, patient control analgesia that we are using for post-op pain relief, is any way it AI can help in predicting the pain, the response to pain, and then whether the dose can be increased or decreased? Self titration. What I mean to say.
yes, it can be done using the AI models. Presently, only it is dependent upon the patient's requirement, but it can be integrated with other monitoring like the heart rate, the respiratory rate, other physiological parameters that will predict that the patient is actually having pain, and then it can be titrated likewise, the patient-controlled analgesia system. However, these are all like into the experimental stage and into the studies, and we have a long way to go to implement it into clinical practice.
It's a very, very interesting topic, no doubt. And you have chosen the most gray area, the lumbar back pain, for your study. So that is, I think it'll give us more insights. And thank you so much for the answer.
So,
I
Dr.
think if there are no questions.
So we'll just have a discussion with, I think, the speakers. They have read so much, we can enhance our own knowledge. Yes.
Bilkul, bilkul.
Dr. Bhargava is there with us. Bhargava also, I think, must have left. So we'll come back to Dr. Prakash.
I
So
see.
Prakash, my question is, how frequently do you think, like in the current gadget area, how frequently do you think in your studies or in your various protocols you follow for conducting the studies or research, AI is being used as an tool or an asset where you think it is beneficial to you and it'll create less bias? Understand? Point is that we are using AI to enhance our research. Now the gray zone has come in AI's own ethics.
Yeah.
Okay, so we feel AI sounds very intelligent and sounds very interesting. Yeah, we are using AI based protocols, something, but the AI's own backend, what is happening, we don't know.
Yes, yes, sir.
So, what is your take on it? How do we solve that black box query?
So it suppose, sir, if we have a friend who is very knowledgeable, and we want him or her to give quick answers and accurate answers, and answers that are that make us happy with our query. This is how AI models are trained, or were traditionally trained. The problem was with memory initially. So with less memory or low memory, so many queries or prolonged duration of interaction with the AI model, now they have to be quick. They don't remember what was initially asked, and now they have to quick. They have to please you. At that point, there's a juncture where AI hallucination comes in. So now, with the neural network, the from the initial prompt to the final output, let's say I have chatted with ChatGPT for like 20 minutes, and nowadays models do have memory, but initially, only like 4 months back, these models were not having a memory updated feature. So they used to forget what was the initial prompt, and now just to please and
I think
satisfy.
from Gemini 2.5 onwards, we have got memory enabled, I guess, है ना?
Yes, yes. So that was the reason. So it has developed, it is evolving. With time, I'm quite positive and sure with time we will have better models. But for now, most of us are using it in one way or the other. Uh, for as per research perspective, generating a hypothesis is a no, because it conflicts that push us in that gray zone again ethically. The novelty or originality of the idea from a human mind. But writing portion, enhancing the grammar structurally, we can definitely use it, acceptable by most of the journals nowadays. Only thing is that we should declare it. Non-explainable AI for now is challenging. The black box effect, if along the neural network for a longer time, if a model has reached to give an output, and if it cannot explain, that is still a challenge. But with better better processor, better training, a good memory means huge memory for the servers, and maybe with time we'll be able to solve this problem also.
Thank you. Thank you so much for that answer. Dr. Pratibha, ma'am, any questions you want to ask, ma'am?
I think any of you can take this question. Actually, in all the four presentations, they have mentioned so many applications. Like Sana has mentioned one application, self-management application, right? So even we have so many smartwatches and so many applications at place. So how do we know that this application, the data or whatever output is coming from through that application is validated? And I mean, who is responsible for that if that data is, it's not accurate, or if something went wrong while using that data or application? I mean, there's so many applications they are talking about. So, like one of the applications, Sana mentioned that it is FDA approved, right? Because in USA, as what there is no legal regulation all over the world except in UK, which is union law in UK, which is the only regulatory body right now, which is as per AI is concerned. In US is also, it is the FDA who is monitoring all these AI products. So what about in India? We are using these applications. So, I mean, who is monitoring all this?
India may ICMR has pushed the responsibility even for development of new tools to the researchers and ethical bodies. And as such, there is no robust law. Uh, who will be responsible? Mostly the user. Uh, user is responsible, because
User.
user means like the researcher basically. Like the researcher is responsible for the for now, because there is no defined responsibility over a medical error. All these models are in nascent stage, especially in India. It has no foolproof model has been released. Nothing that I am aware of.
Yeah, Digital India Act is in pipeline. I think that will cover that thing.
Yes. So for now, to give a very accurate answer to this question is also very challenging. But for now, the responsibility is shared with the researchers and ethics body largely.
Okay.
Madam, can I say a word? I hope I'm audible.
I think I'll
Yes.
just add to this that the AI gadgets, which are commonly are seen, we at Gangaram do have a CLAT system, the closed loop anesthesia delivery system, which is technically an AI based system. And you only have to induce the GA and attach it to the patient. It will maintain the anesthesia with adequate depth. It will also adjust for the hemodynamic fluctuations. Of course, it needs an oversight by a trained anesthesiologist. But yes, we do, and that is also FDA approved. And there have been multiple studies on that system from our own institute. So that is one system which is being in currently active use. The other one, which Dr. Sana has highlighted in her talk, is the ultrasound, the scan nav technology, which has come in the recent ultrasound machines, which you only have to put your probe in the supraclavicular area. It will automatically mark the bunch of grapes for the brachial block. It has now its limitations are a bit only till for the main commonly used blocks like the tap, the brachial, the popliteal, and the aortic canal. It is not for the POCUS right now, but yeah, I think it's a work in progress. And yeah, I think I agree with Prakash that in the end the responsibility lies with the user because it's a tool in the end.
Yeah, Dr. Kalra, can I add? I'm Bhargav
Please,
speaking.
please, Bhargav. We were
Sure.
waiting for you.
Yeah, sorry. I could not unmute myself when you were trying
No
to ask me
problem. No,
something.
Okay.
So
no
the
problem.
issue is, if I'm audible.
Yeah,
Yeah,
yeah.
yeah, you are audible, please.
Right. So the thing is, we did a small, I mean, kind of multicentric trial on the use of digital stethoscope recently. It's under peer review. So we used a particular stethoscope, which the data of which was published from the US and UK data. It is quite popular. It's being used all over. So they said they can predict with the ECG delivered, I mean derived from the stethoscope, they can predict ejection fraction of less than 40%. Right. So the problem is, like he's already pointed on multiple places over all the four speakers we've pointed out. The problem is when we tested it in our population, in Indian population, the results were completely different from what was published. So naturally, the application of that from which where it has been developed to a new population will be a different challenge. So naturally, like he said, no, Dr. Prakash said, it's responsibility of the user. That is surely there. As long as we get more data, and I mean, until we get more data, we still have to use everything with a lot of caution. No doubt about that. And regarding this personal, wearable devices and the data that we do, that is all, everything is being, accumulated. So eventually, all this data will eventually come back to help us. Hopefully, that's all I think.
So it is onus is on us. So we have to use it responsibly, right?
Yes.
Okay.
Yes, madam. Certainly, it's on us. How you apply it, because where it is coming from, like this specific example that I said, no. It's very, we are surprised to find the results were completely different. I would not say inferior or superior. They were a little different from what we were expecting. So we could see it live that, as the population changes, the entire game changes.
Yeah. Which is expected actually. So even if it is FDA approved, I mean, if certain application is approved by some other country, and if you're using here in India, then it's not that you are safe from law. Then the user end where it is that application is using it, the user end is the one that country laws, actually it is governed by that country laws.
The
So
FDA approval is
There's one more
just
issue with this.
Mhm.
Sorry if I'm interrupting someone.
Yes,
Can
yes.
I speak for just a few seconds?
yes, you continue.
So the thing is, let's say this is one issue of using it. The other thing is, if someone comes up to you, or let's say a patient or someone, a next of kin comes up to you and says, the AI thing tells me that this is the best course of management, and you have your own decision based on your own this thing. That's again a dilemma as to what
It's
should be done,
complicated.
isn't it? It has been dealt with partly in one of the talks, but if AI tells you something, he'll show you right on the face that, see, this is what it says. What do you think about this? Then you'll have to, give a justification as to why the other one. That's where, the consent comes up in a big way. And if there is a conflict and you do your way of deciding and doing things and something goes wrong, and probably the relative will come back and say, I told you, see, ChatGPT or something else told me something else, you did it the other way, in spite of taking consent. Then what do we do? So these are all, things which still have to be dealt with.
I would also like to add there was a movie in which Tom Hanks starred, and it was Sully. The movie name was Sully, where the airplane crashed and crashed out. They have landed it safely on the water, and they run AI algorithms later on as an investigation to see if it was possible to land it to the nearby land area. And all the AI algorithms, they do indicate that the pilot was at fault, and it was okay in simulations to land that plane in the safe area and not water, damaging the aircraft. So, but later on, when human elements were applied to this decision making, so even AI algorithms failed in that mode. It's a very beautifully and very relevant to this particular topic. So coming back to what Dr. Bhargava was saying, कि simulations में many times like if there's relatives come with say AI generated responses that this is the best investigation, why are you giving so and so, suggesting so and so investigation, or why you delaying the surgery for anesthesia perspective, then there are so many human elements, clinical knowledge, experience, which AI is missing. AI is trained on some data. That data will always be limited. It will never, the human experience, the machines can never learn human experience. They can be given facts or similar data, but human experience is lacking, and that's where a difference is there.
Absolutely. I think one of the very, very famous examples, if you start, reading about AI, was a study conducted in UK where they evaluated the community for who is better at health, which ethnic community is healthier as compared to the others. So the AI model concluded that the black community is healthier in the UK than the white community, only because the white community was having more access to healthcare, was spending more on healthcare as compared to black community. It never took into the account the social fabric of that community in that country. So yeah, the all the feedbacks, all the social fabric has to be incorporated into AI to give it a good result.
So it's always a data driven. I mean,
Yeah,
it's all
It always
it's
is.
retrospectively.
totally
Yeah.
data driven.
Yeah.
It cannot replace human intelligence.
Yes. That's the
It
silver
is
lining.
yeah.
So, any more questions?
I think so. We can conclude. We have had a very, very good bunch of talks.
Yes.
So, thank you all the moderator, Dr. Pratibha and Dr. Sumit Kalra, and the speaker, Dr.
Thank you,
Prakash,
sir.
Dr. Samiksha, Dr. Bhargav, and Dr. Sana. Excellent presentation, very, and also the audience, those who have interacted with them. And it's really the in thing. We have to see how much it is going to be useful in our medical practice or anesthesiology practice. So thanks a lot, everybody. Especially Dr. Vineet and Vineet Health. Thank you very much for organizing this.
Thank you, sir.
Thank you very much.
Thank you, Vineet, sir.
Thanks a
Thank you
lot.
so
Thank you,
much.
Vinny.
Good evening, everyone. Thank you, everyone. Thank you.
And Shiasi
Thank you,
from the
everyone.
clinic.
Yes, sir.
Chelsea.
Thank you, sir. Thank you so much.
Happy World Anesthesia Day
Yeah.
Thank you.
Yes, sir.
Happy
to all of
Diwali and
you.
happy World Anesthesia Day.
Yes, happy Diwali too.
To all
Thanks a
a
lot.
very, very
Thank you,
happy
bye.
festive season. Thank you to
Yeah.
all the speakers.
Happy and
A
prosperous
very, very
Diwali.
good night from Delhi. Thank you, Prakash. Thank you, Sana. Thank you,
Thank you.
Pratibha ma'am.
Thank you
Thank you,
all.
Dr. Bhargava.
Good
Thank you.
night, all.
Thanks.
Good night.
Good night, everyone.
Good
Thank
night.
you, sir.
Good night.